Hello, my name is Adrian Gardner, and I've been asked to talk around the surgical challenges and backlogs that have been created by COVID-19. I'm going to cover a bit of information about who I am and what I do and what my surgical life was like before COVID and what the effect of COVID was on the surgical services that I offer. Following that, we'll talk about what is happening now and what the future holds for us. So, I am a consultant paediatric and adult spinal surgeon working in Birmingham. I have a particular interest in scoliosis. I work at two sites, the Royal Orthopaedic Hospital and Birmingham Women's and Children's Hospital. The Orthopaedic Hospital is my adult practice, and obviously the Children's Hospital is where I see children. In conjunction with my osteogenesis imperfecta paediatric colleagues, I offer the spinal link for osteogenesis in Birmingham, particularly for paediatrics. Of note, the adult osteogenesis medical services are offered at University Hospitals Birmingham, which is our local university adult centre where I do not work. This talk is going to mostly focus on the spine because that is what I do, but the issues faced by spinal surgeons are the same as those faced by my colleagues that operate on the limbs. So before COVID-19, the service that I work in had a 9 to 12 month waiting list for spinal deformity surgery, so that's scoliosis. We had 4 all-day theatre lists a week at Birmingham Children's Hospital, with lists at the Royal Orthopaedic as well. For us, paediatric spinal emergencies, so fractures, came in under the Birmingham Children's Hospital neurosurgeons, but they were handed on to us for care and long-term follow-up. If you had a child at Birmingham Children's Hospital, you could stay with them 24/7 for one parent, and the other one was pretty much also there most of the time with very relaxed visiting hours. With regards to paediatric osteogenesis imperfecta, I did 2 combined clinics with my paediatric medical colleagues a year. When COVID-19 arrived, we all remember that all of our elective work was cancelled, both our adult and our paediatric work, so on both sides for me. All face-to-face outpatients were cancelled and everything went to telephone, Zoom, or other video consultations. In terms of the adult world, my hospital, which is an elective clean site without an A&E, started to take broken bones of all types from everywhere in the city to try and create capacity elsewhere. We also combined spinal on calls, and so the adult emergency work was taken on by the Royal Orthopaedic Hospital for both us and the neurosurgeons at UHB. So whilst my elective work withered, my emergency work got quite a lot busier. Emergencies continued and we offered all of our emergency care. And when we weren't doing that, we were asked to volunteer in adult intensive care. For theatre staff, and this is particularly at Birmingham Children's Hospital, we lost a number of staff to shielding because they were classed as high risk, and that reduced physically the number of people we had to do the work. For those that were left, they had to cover emergency and urgent care in specialities such as cardiac surgery, neurosurgery, transplants, and cancer care, and some of our theatres were mothballed. My anaesthetic colleagues had to go and work in ITU, whether you were an adult or a paediatric anaesthetist. As normal life now restarts, all of that means that there's been a large expansion in the number of people who are waiting for first-time outpatient appointments to see us with a new problem, are waiting for follow-up appointments to follow up on tests, discussion of treatment or other issues, or are on the waiting list for surgery. And that means that the waiting times for all of those categories has significantly climbed. So, quite rightly you ask, well, what are we doing about it? Everybody who's on a surgical waiting list has been assessed by a consultant to grade where they are against set criteria for the urgency of their surgery. And these are criteria that have been laid down by the Royal College of Surgeons in conjunction with other specialist bodies. We are also doing an in-house harm review where a consultant looks at the patient, their records, their imaging to work out where they are in terms of the progression of their condition and whether their criteria needs to be changed. If people need to come up and have x-rays to allow that assessment to happen, that can happen. This is the Royal College of Surgeons guidance on surgical priority. You can see there are 7 categories. Essentially, category 1 is emergency care. 2 are procedures to be performed within a month. 3, procedures within 3 months. 4, procedures that can wait for more than 3 months. 5, procedures that can be delayed indefinitely. And 6, procedures that are just suspended until after the COVID pandemic has passed. Essentially, off the waiting list. And we're also working to get our capacity back. So as people come back into the work and things are being rescheduled, we now have 3 all-day lists a week and we'll be going to 4 at some point in the future. Our wards are reopening. Our radiology is reopening, so we are able to get people in for imaging. And our outpatients is back online. All of the above with appropriate social distancing. And extra work is being done to try and catch up both in clinics and theatre sessions. As already noted, we're rearranging what we have to make the best use of it to allow for social distancing. So that is ward spaces to get the most people in a safe fashion. And at the Children's Hospital, that's obviously with their parent or carer associated with them. And the booking of radiology. So we are now far more active in pre-booking our x-rays, our MRI scans than we had been previously. And for inpatients, everybody gets screened. But what is the size of the problem? Well, this is just the waiting list at Birmingham Children's Hospital on the 19th of April 2021. All spinal cases under the care of my service. So there's no emergencies, as you would expect, but there's 34 P2 cases, 22 P3s, 92 P4s, 5 P1, 2 P5s, and 1 P6 that's come off the waiting list. So as you can see, there's a lot of people awaiting surgical intervention. And the numbers are overwhelming our current capacity. And of course, we're adding to that all the time as we now start to see the people coming back into outpatients who have been delayed and need surgical care. So our challenges for the future are catching up to where we were and getting back to what we had pre-COVID-19. And also dealing with the bigger surgical problems that have resulted from the delays inherent in shutting everything down as we had to do last year. Scoliosis will have got bigger, magnitude of surgery required to sort that will get bigger. And that just takes more time, more effort and more resource. But there is some good news. All healthcare people in Birmingham are now vaccinated. So we are able to provide the staff to deal with the problems. And it seems to me, as a simple bone man, that the COVID-19 burden for the UK seems to be becoming less of an issue. All of our PPE supplies have been appropriate, maintained, and we've never had a problem. We have an expansion in our service occurring over the summer in Birmingham, so we'll have more people. And there genuinely is a will to try and solve these issues. Thank you very much for your time, and I'll happily take questions.
Thank you, Adrian. Did you want to just give us a brief update on what's changed and what's current?
So certainly, thank you. The add to all of that is that there is now a plan to group hospitals together. So what's been labelled as a system response, and that works practically in that hospitals are actively banding together as a gang to try and even out waiting lists across areas. That should mean that whilst everyone has a greater waiting list, you don't get penalised for being on the waiting list in, you know, the hospital down the road because you're under Mr. Smith, whereas, you know, if you're under my care in my hospital, the waiting list is shorter. So we're seeing in both hospitals I work in, surgeons that wouldn't normally work there from other hospitals coming in with their patients to at least make the playing field level.
Thank you. I can't see any questions on the chat, but I was going to ask you. Oh, Elaine.
Can I ask a question? I'm a bit concerned that a lot of our OI children have been off school, at home for very, very long periods of time. And I'm wondering what the impact that will have on them with regards to scoliosis. Because I know from my own experience, having 2 children with OI, that the way they sit and how long they sit in awful positions that they shouldn't be sat in has had an effect on them in the past. And I'm just concerned that a lot of our children have been at home, you know, not sat in good positions, not walking or not sitting upright. And I'm just wondering what the impact that might be, and if anyone's thought about looking into this for me, because I'm very worried.
Fair enough, and a very good question. Thank you. I mean, the honest truth is that I suspect all kids of all diagnoses, and OI certainly, have lost out from not being active, not getting out, not exercising. And we all know, you know, you don't do stuff, your muscles get weaker, you become less able. The bone changes of scoliosis probably aren't affected too much by that, but you know, scoliosis is more than just the bone, and having all of that muscular support around it will inevitably have an issue. And then if you're trying to fix a scoliosis or any you know, bone problem, having a good quality muscular envelope around it to get you up and get you going is vitally important. And if that's not there, it's harder for the person to recuperate and rehabilitate. In terms of your second question, I'm not aware of anybody that's looking at that specifically in the OI group. We're aware of it generally across all musculoskeletal health, and there are plans to try and address that sort of more globally, I suppose.
Thank you.
Okay, we've got a question from Thines. Great talk. Does the RCS guidance of prioritization take into account quality improvements to patients when this exercise is being done?
The RCS guidance is reasonably bland, and it sort of comes down to, here are some criteria, now Adrian, go and put these people into slots as best you feel able to. So from a personal point of view, you know your patients and you try and do the best for them in the totality of their care. And even as an orthopaedic surgeon, I do try and look outside just of the bone and the spine. I do my best. But I think it comes down to that relationship of the clinician knowing their patient group, knowing their children, knowing their adults, knowing their patients.
And you may not be able to answer this, Adrian, but what can many of our audience do to help this process? Obviously, everyone in the healthcare system is under enormous strain. We're having to change very quickly, almost on a weekly basis. Are there any things our audience can do to help you and other surgeons make sure they're in the right slot, as you said?
I think it's about keeping in touch. You know, I suspect my secretary will shoot me for saying this, but, you know, information is power. And so if you are in a position that you're waiting for an operation or you're waiting for a test and it's got lost in the system, we don't know about it, you think you should have heard, please tell us. I don't promise I can fix it, but if I know there's an issue, I can do things to try and reshuffle things and sort things out. And I think if, you know, and particularly in the osteogenesis population and this group, you know, you're the experts. And so actually, if you can turn around to me and say, look, things have changed, I know my body and this has happened, you know, I'm going to take it seriously. But I need you to tell me. And I think that's the honest truth. Of course, swamping the phones also is a counterproductive thing. So it's finding that balance between the two.
That's very sensible advice. Thank you. And an impossible question, but when do you think this will all be over? The backlog will be cleared?
Well, all I can do is look back at when the waiting lists were this bad, you know, 10, 15 years ago, and it is solvable, but it took investment time and sort of 6, 7, 8 years worth of work. So I think we're, you know, as long as things continue to settle, I suspect this is something that will last for the next decade. And
okay, so we have to keep an eye on this.
Yeah.
Great. Thank you so much, Adrian. We will have you back at the end if you've got time to take any other Q&As. Thank you so much.